Hi, my name is Hannah Hunt and I'm going to talk today about a drive-through service that we implemented in Cardiff and Vale University Health Board in response to the COVID-19 pandemic. So in March 2020, the direction came to reduce footfall through the hospital. We needed to reduce patient contact, reduce patients coming into the department to allow for social distancing, yet we needed to complete patient consultations and provide them with diagnostic study equipment or CPAP therapy treatment. You'll see a little later in the presentation that our waiting times pre-COVID were at an all-time high. We were struggling to create the capacity to meet the demand on the service, and that was without all of the COVID restrictions coming into play. Very quickly, it became apparent that our traditional face-to-face model would not be suitable. So the team at the University Hospital Landoc brainstormed alternative options, and within a week, the first patients were booked into our brand new drive-through service, which you can see on the screen here. Despite the obvious change of moving outside, there were only a few subtle changes that we needed to make to our pathway in order to implement this service. As with most services, the referrals are received and triaged to make sure that they're appropriate for the service. We've been physiologist-led in Cardiff and Vale for a number of years, so the patient's first appointment is with a respiratory physiologist rather than a consultant. The first major change we made was to split that first appointment into two separate contacts. The patients would have a pre-booked telephone consultation with the respiratory physiologist, followed by a separate appointment to collect the sleep monitor via the drive-through service at a later date. This enabled us to use the appropriate level of staff for each contact. The previous pathway had all been undertaken by a Band 6 physiologist, but the new model enabled us to use the Band 6 for the telephone consultation and a Band 3 to issue the sleep monitor in the drive-through. The next change was to split the face-to-face CPAP collection appointment into two separate contacts again. The patient would then have a pre-booked telephone consultation to explain their results of their sleep study, to discuss what obstructive sleep apnea was and the pathophysiology of it, and any DVLA advice that would be applicable. They would then be booked into a separate appointment to collect their CPAP machine from the drive-through. We found this gave patients a bit more time to absorb the information we were giving them prior to the collection of their CPAP machine. Often they would arrive having done a bit of background reading, so they were a lot more knowledgeable about their condition and about the machine they were about to receive, and that was of huge benefit to them and to us. The final big change was the utilisation of remote monitoring to enable us to follow up our patients virtually. Previously, all our patients were seen face-to-face, and not only was it an issue for COVID, but again, we were struggling to create the capacity in our traditional clinics to see all of our patients on time. So how did this affect our service? So this is the slide that gives me shivers a little bit. It doesn't really paint a great picture of our service prior to the implementation of the drive-through model. As I mentioned earlier, we were really struggling to create capacity. A patient would be waiting around 57 weeks for oximetry, which is the basic level sleep study, which is the green line on the graph. If they then needed a further sleep study, a limited channel sleep study, they could be waiting another 55 weeks, which is the purple line on the graph. And if they needed CPAP treatment, that was a further 28 weeks, which is the blue line. It's quite common for a patient to need both levels of sleep study before needing CPAP. So if you add all of those together, at our peak, we were hitting 140 weeks from the time of referral. The drive-through was then implemented at the end of April, and capacity was increased throughout May, which resulted in us seeing a rapid decline in our waiting times throughout June and beyond. Thankfully, this remains the case, and our waiting times over the last 10 weeks have averaged at around about 24.7 weeks. Over the first 12 months that the drive-through was up and running, we were able to perform over 1,800 diagnostic studies and set up over 700 patients on CPAP. These numbers are still rising and quite rapidly because the service is still running via the drive-through. So what effect did this have on our patients? So we audited the data and we could see a 17% increase in our CPAP compliance. If you're unfamiliar with CPAP and the treatment and what's involved, compliance is a measure of how often and how long the patient is using the machine for each night. So 17% increase we felt was quite significant. We had an 11% decrease in large leak, so the masks were fitting a lot better. That was quite a surprise to us because we weren't able to do our traditional close fitting mask checks. We previously would bring patients in, put the mask on them, adjust them, so we'd be very close to them, and then we would turn the CPAP machine on to get a bit of pressure through it to check the fit. Because of COVID, CPAP was classified as aerosol generating, so we were unable to do that. So we had to kind of get used to and adapt to just eyeballing our patients and picking the best fitting mask and sizing them up without sort of getting too close to them. So we were really surprised to see an improvement in our large leak statistics. We saw a 2.59% decrease in AHI, so the patient's sleep apnea was better controlled. They were having less pauses in their breathing whilst on CPAP treatment compared to our traditional model. We believe these improvements were achieved because patients were utilising the DreamMapper app a lot more. This is the patient-facing element of remote monitoring, so not only could we see the data, but they could as well via an app on their smartphone or tablet. It would provide them with information about their usage, their mask fit, and the control of their sleep apnea. And if there was a flag on any of those things, there were troubleshooting guides that they could watch and learn how to sort of adjust their mask and that sort of thing. If there was any problems flagged up on their data, they could phone us, we could access the data, and we could actually make changes to the settings of their machine remotely. We wouldn't have to wait 3, 6, 12 months to see them in clinic, only to find out that there was a problem a couple of nights after their last appointment. So we did run a patient satisfaction survey. We knew all of this looked good in terms of our waiting times, and our stats looked good in terms of the patients using the machines, but we wanted to make sure that they still felt that they were getting a really meaningful service, that they had time to discuss their problems, and that they felt that the drive-through was a safe option. And you can see through the graphics on the screen, the feedback was largely positive. A small proportion would have preferred an appointment within the department for various reasons. Some of the common themes of the feedback were mainly around parking. They were really pleased that they didn't have to fight for a parking space or arrive an hour early for a parking space. They could turn up, they knew the space was there in the drive-through, and they were back off site within about 20 minutes. That resulted in them having to take less time off work. So for our patients who were working, they could either take some time off to take the telephone consultation, or if they knew they needed to come to the hospital, it was a lot more efficient and less time off work for them. We can't really talk about the drive-through without mentioning a couple of the challenges that we faced. There were a few sort of bumps in the road as we went, the weather being one of them. As you could see from the first slide, they were sort of quite temporary structures, so they did threaten to take off a few times in high winds. Mask fitting, as I said, it was a little bit tricky, but the staff sort of adapted how-to guides and pictures and everything to give to the patients to try and make sure that they were as familiar with the equipment as they could be. We also had a slight issue at the beginning with patients who were shielding. Obviously, the government advice was for them to stay at home to protect themselves, and we couldn't then invite them to the department or to the drive-through to collect this equipment. So we were fortunate that we had access to a courier service, and they would sort of deliver the equipment or collect the equipment from the patient in a COVID-safe manner. I'm not sure if I'll get any thanks for this, but I did want to sort of pop these the team's photos on just to sort of give them the credit for this. Really, this has been a huge team effort, not just from the sort of brainstorming and development of the idea, but through constantly reviewing, changing the protocols to make this service as efficient as possible. So this is the whole team, or the vast majority of the team at the University Hospital and Doc, and without them it wouldn't have been possible. Thank you very much.
My name is Jonathan, and I work as a clinical scientist in the Rehabilitation Engineering unit in Swansea, and I'm also currently undertaking a PhD at Swansea University. Today, I'll be presenting a brief overview of the results of 3 case studies where we look to develop customised assistive devices to engaging with the end user. Assistive technology has great potential to improve function and independence in individuals living with long-term health conditions, reducing the burden of their condition on themselves, family, and the health and social care systems. However, to date, this potential is not being fully realised. Previously, we have conducted research to identify the barriers to assistive technology use across a range of health conditions. Barriers identified including those related to the design, function, and service provision of assistive devices. Further information on this work is available from the paper cited below. This current work looks to address some of the specific barriers around a lack of customisation of assistive devices to an individual's needs, a lack of user involvement in the design process, and in decisions related to their care. These barriers relate to the 2 main questions posed. Through working with the individual throughout the design process, referred to as co-designing, we are initially looking at if it is possible to co-design customised devices within a healthcare setting and the implications of this way of working. This work was conducted in Swansea Rehabilitation Engineering Unit, with all appointments with the participants conducted virtually. In this work, we focused on physical mechanical devices. Designing the devices followed an iterative approach, where the design ideas were turned into prototypes using computer-aided design tools and a 3D printer. These prototype devices were sent out for the participants to trial at home, and after a few days, we arranged a virtual appointment where participants provided feedback on the devices. From the feedback, the device designs were modified and improved, and were then manufactured again to be sent out for the participants to trial. This went on for 3 to 4 iterative cycles over a 3 to 4 month period, after which the final devices were issued to the participants. Evaluation was conducted using a mixture of semi-structured interviews and standardized assisted technology questionnaires, although due to time restrictions, I'm not able to go over the questionnaire data today. We also looked to estimate the cost of developing the devices, including the clinician's time and the material costs. 3 participants were involved, and here I provide a brief overview of each. For each participant, we initially asked them to identify the challenges of daily living they struggled with and what was most important to them. A range of challenges were identified, each individual to the participant. For participant 1, she's hoping to use an eyeliner pencil herself and help to tie up her hair, as this is something she'd never been able to do herself. She struggled with gripping and holding small objects and being able to twist her hairband to tie up her hair. Participant 2 had amputation of her middle 3 fingers on her right hand. She wanted help with cutting food at the dinner table as she was unable to hold a knife, and also wanted help with holding a pen again for writing in her right hand, as she hadn't been able to do this since her accident. For participant 3, she had been prescribed a medication, Sativex, which is administered orally. However, due to the small size of the bottle and her limited hand strength and dexterity, she was unable to administer the medication on her own and had to rely on her husband. Here are the images of the devices I created and issued to the clients. When developing the devices, we focused on simple-to-use, customizable solutions. The dimensions of each device could be easily reconfigured, enabling the participants to trial different sizes of the device to find the best fit for them. In each instance, I provided the material cost of producing each device again. Devices A and B were for participant 1. Device A, developed from being able to just hold an eyeliner pencil, be more adaptive in being able to hold a range of different devices, with her using it to help hold pens, nail file, and cutlery, amongst other things. Device B is an adapted hair scrunchie with a toggling elastic. When one of the hair scrunchies is pulled, the elastic in the other is tightened, securing the hair into a ponytail. Participant 1 was successfully able to use this, with it being able to stay in her hair all day. Devices C and D are for participant 2. Device C is a knife holder which drops onto her hand, with the knife sliding underneath the holder on a rail, which the participant was able to fit and change herself. Different size attachments were provided so that she could use different size knives in the kitchen to help prepare food. Device D is a pen holder, positioned between the little finger and the thumb, and enabled the participant to support and use a pen again. Device E is the holder for the Sativex medication. The bottle sits in one side of the holder, and when the user squeezes on the trigger in the center, this pushes down on the nozzle of the bottle and sprays the Sativex into the user's mouth. Participant 3 was able to use this to administer the medication on her own. 3 months after issuing the devices, we invited each of the participants to provide feedback via a semi-structured interview on both the impact the device has had on their daily lives and how they found being involved in the process of designing the devices. The transcripts from the interviews were thematically analysed to identify commonalities in the responses. Relating to feedback about the device, participants described how the devices made them feel more independent. For instance, participant 3 was able to administer the medication herself, and participant 1 was able to do more activities with the kit, which she hadn't been able to previously do and had to rely on a partner for. All participants also felt less anxious when doing tasks, felt safer and more confident in performing both the tasks identified as well as other tasks. Participants also felt additional health benefits, such as reduced pain, benefits for their mental health, and being able to use the devices for tasks that they weren't originally intended for. Relating to the service of providing devices, participants were very positive about being involved. They felt it was important to be involved in the decisions, liked being able to provide feedback on the designs that were listened to, and felt it was important to work closely with the clinician to ensure the devices were suitable to meet their specific needs. I've included a quote from participant 1, which highlights to me why involving the end user was so important for this approach, but I also think can be applied more widely. Additionally, participants were positive about the use of virtual appointments, but they like not having to travel for appointments and be able to try the devices at their home. This feedback was concurrent to the scores we got from the questionnaires we sent out, relating to satisfaction with the devices and the psychosocial impact of using the devices. I have presented figures that provide an average estimation of the clinician's time required to develop the devices, including the time for appointments with the participants, as well as the cost of the time and the cost of material. The highest cost was associated with the clinician's time. Some final concluding thoughts. In this small study, we've shown that it is possible to engage with the end users of assistive technology to develop simple, customised solutions to overcome challenges of daily living. These challenges, and hence the solutions provided, were varied even amongst a small sample size. The benefits of providing these devices went beyond the simple use of the devices for their task identifiers. Devices have much wider impact related to other aspects of health and well-being, which are often difficult to measure and quantify, but are important for the individuals using the devices. However, this approach is potentially time-consuming and costly to do, and this needs to be taken into account for looking at the sustainability of this approach. Although it should be considered against the potential additional costs if the devices weren't provided and any knock-on impacts to other health and social care services, as well as providing a device which isn't suitable and would likely be abandoned by the individuals. We're currently looking to expand from this exploratory study to look at if it is possible, if this approach is feasible and sustainable on a larger scale, and what types of challenges and devices are identified through a larger sample size. We also want to look at, could any of the devices be developed to be used by other individuals, as this may help balance from the initial costs involved with the time required to develop the devices initially. We can also look if any further customization of the devices is required. Thank you for listening, and I'd like to acknowledge the support my supervisors have provided me. I welcome any feedback or questions related to this work, and I'm happy to share more detailed results.
Good afternoon. My name is Jenny Townsend and I'm a clinical scientist working in audiology, and today I'm going to talk about the introduction of remote care into the North Wales Cochlear Implant service over the last 18 months. Just to provide some context, the Cochlear Implant service supports adults with a severe or profound hearing loss. A cochlear implant is a medical device that can effectively restore some degree of hearing sensation in this population. There are two main parts: a surgically implanted device that sits under the skin, and an external sound processor that needs to be worn like a hearing aid to give the sensation of sound and to help people understand speech. There's a detailed assessment process prior to consent, followed by an intense period of rehabilitation and programming for several months after surgery. Once hearing performance is stable, regular follow-up and maintenance of the device continues for life. As a tertiary level specialist service, we see patients from a large geographical area covering the northern half of Wales and the Mersey Cheshire area of England. During the pandemic, we were able to rapidly adopt a number of new processes to support our implanted patients remotely. These included using video appointments for assessment, counselling and rehabilitation, which was necessary as the majority of our caseload are unable to use the phone. We piloted continuing our very active user support groups by video conference, which was welcomed by our patients with the help of live text subtitles and the chat function. Indeed, 95% of participants reported that they'd be willing to continue attending future virtual user groups. We also moved to replace some face-to-face appointments by postal support, such as processor repairs and routine processor upgrades. We found that in general, this was very acceptable to patients, with access to email or video call support from the team if required. And we plan to continue offering these changes as an option going forwards. What I'd like to focus on today, however, is the introduction of remote care apps. We were quite fortunate in that the main manufacturer that we use, Cochlear, had recently started a limited pilot of their new remote care app when the pandemic began, and they moved quickly to open the pilot up to all UK centres. We were able to gain the necessary information governance approvals by August 2020, so we could begin to offer this option to our patients. The pilot is now complete and Remote Check has now been fully launched in the UK. The concept of Remote Check is that if a patient has access to a suitable smartphone, they can download the Remote Check app. This allows them to connect up to their sound processor via Bluetooth and do various checks which they can then send to us via the app, including tests of the implant and processor function, photos of their implant site, speech and hearing tests, and a questionnaire to identify any other problems they may be having. We can then review the results on a secure online portal and decide how to manage any problems, for example, by providing advice via the app or offering a clinic appointment if required. We can prompt people to complete a check at regular intervals, or we can request a check if a problem is reported. For example, in the event of an impact over the implant site, we can check that the implant is still functioning properly without the patient coming into clinic. The original app was restricted to patients on the latest generation of sound processors who were also iPhone users. However, it has recently become compatible with certain Android phones and a wider range of implant and processor types. This is a view of the clinician portal demonstrating the dashboard for one patient's remote check. This patient is showing a slight improvement on her last speech score, but in the comments at the bottom, she's noted that she doesn't feel she's hearing quite as well. So we can reply to her in the app to find out a bit more. We can then click onto each icon to drill down into the data to explore any issues that might have been raised. For example, you can view data measurements from individual implant electrodes to check for any signs of malfunction. And you can also view data logging information to see if their patterns of use or listening environments have significantly changed. So the broad range of data we have available to us to review is incredibly useful for making clinical decisions. In our local evaluation over the first 12 months, we enrolled 51 participants, totalling 12% of our caseload. The fairly low uptake was mainly due to the low numbers of patients who had the correct combination of the newest sound processor and a smartphone, an iPhone 5 Plus. The number of patients who can access the app is increasing significantly over time. For those who completed a remote check review, the outcome in almost 3/4 was no further action, potentially saving an unnecessary routine clinic visit. 10% required a clinic visit, mainly for programming adjustments, which cannot currently be done remotely. Another 13% required another type of action, for example, posting out spares or emailing a link to an appropriate online video to support self-management. As our cumulative caseload continues to grow, the option to conduct remote monitoring will be incredibly helpful to reduce pressure on clinical space and time, as well as reducing travel costs for patients and reducing carbon footprint from avoidable patient visits. Since then, we've had some further good news in that in October 2021, the FDA in America have approved the next generation of the app, now called Remote Assist, and UK approval is expected in spring next year. This will expand the functionality of the app to allow us to undertake programming changes remotely alongside an embedded video consultation platform. This functionality will also be available for a wider range of hearing implants, including bone conduction implants, and we will then have the capability to conduct the majority of our post-operative work remotely, which is a major step forwards. I think it's very clear that remote care, both in audiology and in other healthcare areas, is developing very quickly and has great potential to benefit both patients and the NHS. However, in order to realise these benefits, certain support really needs to be in place. Timely and responsive information governance and IT support is really essential to allow us to keep up with the pace of change that's being driven by our healthcare industry partners. A further challenge is how to ensure full equity of access to these benefits. We need to support our patients to engage with the technology that they need to connect with us. Not all our patients can afford a suitable smartphone or would have the confidence to be able to use it in this way. We must now explore options for both improved patient education and training, and to ensure there are alternative ways for our service users to access the technology they need to connect with us. Perhaps this might involve community or third sector involvement to ensure that nobody gets left behind in the ensuing remote care revolution. Thank you.
Good afternoon, and I thank you for giving me the opportunity to present at the All Wales Conference today. Today, I will present a respiratory diagnostic project that was developed in Powys Teaching Health Board during the COVID pandemic. The objective of the project was to provide spirometry testing in a safe way to our patients. Spirometry is a very common test and used in the early diagnostic pathway in patients that are presenting predominantly with respiratory symptoms. As you can see from the picture below, it involves an individual blowing into an open-ended tube and in various ways. Whilst they do that, measurements of airflow are taken to help guide a patient's treatment and diagnostic pathways. During COVID, access to this test was halted for a variety of reasons, and as a result there was a large waiting list that developed. By the time I joined Powys Teaching Health Board in May 2021, there was a large waiting list of approximately 200 patients waiting for testing. The main issue surrounding spirometry, which is still ongoing, is the debate of whether spirometry is an aerosol generating procedure or not. Infection control requirements for an aerosol generating procedure are much more strict and include ventilation requirements, or a recommended number of air changes in a room per hour. Additionally, if spirometry itself is not an aerosol generating procedure, is cough. And this was significant as patients do often cough at the end of a spirometry test, and in fact patients are sent to respiratory physiology departments or to respiratory nurse practitioners for a cough query cause. The debate around this is far beyond the scope of the 8-minute talk that I'm here to do today. The debate is still rumbling in the background and has been for the past 18 months. At the point that this project was penned, spirometry was being treated as an aerosol generating procedure by all of the governing bodies, although had not been identified by NERVTAG. Using the guidelines that were available at the time, this meant that the capacity of spirometry testing throughout Powys had dropped to 15 patients per week, as there was a 3-hour fallow time between each patient. Without additional referrals being received into the service, this would mean that a patient would have an additional 14-week wait to perform spirometry, which would cause delays in their pathway and limited the accessibility of patients to get therapeutic interactions or pharmaceuticals required for their patient pathway. So, although the infrastructure of Powys is small, with old buildings and limited ventilation, we do have a significant amount of large, open, outside space throughout the county. And this is where the idea of taking the clinics outside came from. The project needed to keep as much activity away from NHS sites as possible. The proposal was to use drive-through clinics, and these would involve patients being scheduled an allocated appointment where they would drive to a testing site, have their history and contraindications performed, and then perform the spirometry testing, if required and if suitable. They would then leave the site in the car. This would increase the capacity to 10 patients per section. Now, there were some barriers to the approach initially, and it is a radical solution to the problem, or at least it was in May 2021. There was some apprehension about taking clinical testing off-site. However, as COVID testing had already been moved into this sort of model, that did make it a little bit easier to incorporate into NHS testing. However, outside spirometry did lead to some very unique problems, particularly as we live in Wales. Air itself changes its properties in different temperatures and humidity, and if you have the clinic outside, then these factors of air are much less able to be controlled. So a spirometer was needed that would operate inside a larger clinical range than would normally be required. Once this was overcome, we needed to find some sites. So throughout Powys, we're very fortunate in that leisure facilities are available throughout the area. And these sites are often very large, accessible, they're not isolated, they're free to use with CPR facilities on site. So they actually ticked a lot of boxes. In addition to that, patients are familiar with the locations of leisure centres, so they'd be easy to find. However, on the 16th of December, lockdown rules changed and all the leisure centres were closed, which did delay the start of the project. Alternative sites were found, and the largest one that we looked at was the council site in Llandrindod, Here you can see that we use sites throughout Powys, and specifically Llandrindod, the county council offices, were our largest used site. The reason being is it still fitted all of the criteria that the leisure centres had. Additionally, they were working on a skeleton site, so although it had a massive car park, there were very few people there using it, and CPR facilities are available in the reception as well. So patients were able to get to this site. It had a large car park, safety factors were taken into consideration, and the capacity of the site to house the clinic was very good. And then as leisure centres started to open and more sites started to open throughout Powys, we had large numbers of clinics in the south also. North Powys, there weren't many outstanding clinics, and although we're unsure of the reason for that, there is some hypotheses regarding the number of patients that needed to access testing at this time. So the reality of the model was, of course, there's advantages and disadvantages. It did bring testing closer home to the patients, increased capacity of the testing, and specifically it did address the growing waiting list, which was its primary objective when it was penned. There were no increased footfall into NHS sites, as all the clinics were held out of the way of open and operating NHS services. One of the advantages to this model was because it was very radical, that it was a qualified physiologist that provided the patient testing. Although this would not be cost effective moving forward, this did have the unseen advantage of having advanced history taken, clinical examination, oxygen review and medication review available to the patient as part of their appointment. This enabled patients to be signposted into virtual pulmonary rehabilitation, OT and oxygen services earlier in their journey. Clinics were able to operate even when COVID cases increased. Because there was no implication for the sites due to the different lockdown rules, then the clinics were still able to run. Of course, the major disadvantage in Wales was the weather. We did try to get funding for the model to be run in the south of France, but it just couldn't be stretched that far, unfortunately. Although patient mileage was decreased, it did increase staff mileage, and there were some issues with patients that were hard of hearing. Obviously, a mask is very difficult for these patients, but a mask and their car window made communication much more difficult. And patients with no access to transport did have limited access to the clinics, unfortunately. Some patients brought the whole family and even the pets in the car. And an early lambing season did mean that a lot of appointments were wasted in spring, as there were lots of short notice cancellations. Although I liked that bit because it was a bit warmer than the February clinics that we had. The feedback from the service has been very good. Patients felt that they did benefit from having the clinic done outside and not waiting for the test. And the evaluation period is still ongoing, where we're looking at diagnoses. Did any diagnosis change? The suitability of testing, waiting times, patient miles, and awareness of respiratory medicine. Again, it was really beneficial as this became more apparent as the project went on, that more awareness was being undertaken, and more networking with primary care, secondary care, and also third party was really important. We have massive links with the volunteer services now who support some of our more virtual work. So although the model is currently not our first line for the service, the resources and the governance to run this type of model are being kept current, because Powys Teaching Health Board are keen to keep a responsive respiratory service, and if we are able to keep this model current and keep the policies up to date, this model of testing can be rolled out at very short notice should lockdown happen again, or should there be restrictions placed on infection control policies within our buildings again. Being able to revert back to this model of care will reduce the disruption to patient testing. So although it was cold and in some points very challenging, it was very rewarding, and we've had great feedback from students, staff and patients that work with the model. We've been very lucky. I would like to thank everybody involved with the project, the transformation team, and a lot of very cold Swansea Bay University students that contributed to patient testing. And also thank you to the North Powys project for the transformational funding to make this pilot actually workable. Thank you.
Hi, my name is Jen Taylor and I work for the Radiation Protection Service at Velindre Cancer Centre. And my talk today will be on my master's project that I completed this summer, which was the impact of methodology choice on dose audits for radiology. Now, before I go into too much detail about that, I think we can all agree that radiation services are fantastic. The ability to see inside a patient and to be able to diagnose a broken bone or a blood clot or a brain tumour without actually having to go and, do invasive procedures is brilliant, and it's really transformed our healthcare services. And loads of these scans are performed every day. It's very likely that we've had one in our lifetime so far. If not, we will do. 45 million of them were performed in England and Wales in the year 1819, and of these 45 million, 30 million of them involved ionising radiation. Now, there's that word radiation, which often has a bad reputation, and we do need to be careful with it, because ionising radiation is harmful, or can be harmful. It can damage DNA, which can lead to cancer. So we can't escape radiation. It is all around us, and there's nothing we can do to get rid of it completely. But what we can do, what we do have control of, is the amount of ionising radiation we're exposed to during our medical procedures. So we do need radiation dose to get images often. So there's a constant battle in the land of medical physics between radiation dose and image quality. Obviously we don't want too much dose, unnecessary dose, because that could have bad effects for us. But at the same time, we also don't want too little dose, because then we won't get a very good image, and then that won't help us either. So there is a sweet spot in the middle that we need to find this balance with. So we want enough dose to give us a good image, but not too much that it will unnecessarily cause us harm. So there is a word for this, and we call it optimization. And optimization is one of the main things that we do. So we want to look for ways to keep the dose as low as we can, while still maintaining diagnostic image quality, and this principle is called ALARP. So one of the ways that we do keep doses ALARP is by using something called diagnostic reference levels. Now, diagnostic reference levels, or DRLs for short, are a way that are used to track dose, and we do this through dose audits. So we look at all the medical imaging scans that have been performed, for example, chest-X-rays at a certain health board for a few months, and we say, okay, what is the average dose here? What is the most, the dose that we're getting, the dose that we imagine a standard size patient to get from this scan. And we do some statistics on this, and we come up with our diagnostic reference levels, our DRLs. Now, all other scans are compared to this diagnostic reference level, so it is important that this level is right, and there are ways that we can do this. So we know we need diagnostic reference levels, but how do we get them? So these two books here, IPEM and ICRP, these books were written by two great groups of people who are very knowledgeable in the subject area and do provide us some great advice and guidance on how to calculate DRLs. However, unfortunately, this guidance is conflicting. These two books don't agree with everything, so it does leave a bit of interpretation from our end about how best to calculate this. So something they don't agree on is the mean and median, so which is the best average to use, how many data points we need to get a reliable result. So one of the books says we need at least 10 points, and the other book says no, 10's too small, we need at least 20. So there are some grey areas here, and my project aims to iron out these grey areas and find out, okay, I'm going to do lots of statistics and find out exactly what the right numbers should be and how we should measure this DRL level, because it is so important. As I say, my project aims to look at these areas, so mean versus median, which is better, outliers, do we kick them out or do we leave them in, and sample size, how many points we want. So this is what my project focused on. And the way I did this is I collected lots and lots of data, and I analysed lots of data and processed it to create some graphs and diagrams. So this is an example of one of the spreadsheets that I use. So again, lots of data points here, lots of rows of data, lots of statistics to do. And I did come up with some useful findings. So my findings: dose, DAP values. So DAP values are an indicator of dose that we use to measure our DRL quantity. And we found that although there are lots of small points towards the left-hand sides of the graphs, there are a few that are larger. So these would be outliers that could potentially skew our data. And this is important when we talk about mean and median. So we really want what we to do is iron out this data, and we want to get rid of those outliers. So by doing that, our graphs change a little bit, so it gets rid of the tail at the end. We looked at mean versus median, so blue is mean and red is median. What we want is for the two with outliers to be, we want them to be the same. We don't want there to be a huge difference between the two. And as we can see, the red box, so the median box, is more consistent across it than the blue is. It's not perfect, but it is better than the blue, than the mean, where there is quite a big of a gap there. And these two graphs at the bottom are box and Worcester diagrams, and they look at the sample size. So blue is 10, orange 20, grey is 50, and yellow is 100. And what we're looking at here is the smaller and thinner the box, the better. And the bigger the box, that's not good. We don't want that because it's related. It makes it look unreliable. So the smallest sample size is the blue is 10, and that's a huge box. That's not very good. And the thinnest box here, so our best sample of data that we have is when we took samples of 100. Okay, so the greater the number of data points we had, the more reliable our result is. This is echoed here actually. So it's important that once we've got our DRL value that we can notice if it changes at all. We want to be able to tell it changes, because that could mean we could come in and optimise. And the way we look at that is I basically ran lots of tests again, and I introduced a 20% change and saw if I could find it, if I could detect the change that I know is there. Green means yes, I can detect it, which is good, and red means no, I can't. So as you can see, what we need to focus on here is that 10 and 20, not too great, didn't detect it a lot of the time when I know it's there. But when I use sample sizes of 50 and 100, I could detect it, which is great. That's exactly what we need. So just to summarise quickly, there's no gold standard yet for calculating DRLs. It is down to each health board with advice from a medical physicist. What my project found is that the median is more reliable than the mean. Outlier exclusion should definitely be applied, sorry. And I disagree with IPEM and ICRP here, and I'll say that actually you need a sample size of 50 rather than 10 or 20 for a lot of these results. So that's a quick whiz through my project. Very much welcome questions and comments if you'd like to get in touch. Here's my email address, but thank you very much for listening, and I hope you enjoy the rest of your day.
My name is Stuart Baines. I'm a clinical specialist radiographer within Morgannwg University Health Board. I'm going to be chatting to you today about our GP Chest-Xray hot reporting project with same-day access to CT scanning. So to give you some background in terms of lung cancer, we know in Wales lung cancer is the leading cause of cancer-related death, with twice as many cases as colorectal cancer, for example. And we know that as the stage of lung cancer increases, the survival rates exponentially decrease. So if we can detect lung cancer early, that significantly improves the outcomes for these groups of patients. And the red arrow on this graph just shows how poorly the UK performs when compared to other comparable European and worldwide healthcare economies in terms of their 5-year survival rates. And this is what it's all about, detecting lung cancer on a chest X-ray, which is the first imaging modality that we choose. This shows a left-sided 9cm upper lobe mass. And the chest X-ray is a 2-dimensional representation of a 3-dimensional structure, and it can't give us detailed staging information about the patient's lung cancer, which affects the management of the patient. So we then undertake cross-sectional CT imaging of a patient, where we can interpret thin sections through the patient's lungs and get much more detailed information about that cancer, which affects the onward management and treatment options for the patient. So why did our chest X-ray project come about? Well, the Welsh Assembly Government in 2019 set out the National Optimal Pathway for Suspected Lung Cancer, and this set out the gold standard investigation of lung cancer to allow patients to begin definitive treatment within 62 days from that point of suspicion. And some of the key areas on radiology within this pathway were a chest X-ray performed immediately with a same-day report, CT staging on the same day or within 72 hours. And if that was abnormal, having a system in place where we could onward refer to a chest physician urgently. And the patient should be within the MDT setting within 7 days of that initial referral. So that was going to be a huge challenge for radiology across the country. So I thought it'd be useful just to give a pre-project example timeline of a patient that arrived in 2019 with a mid-zone opacity. GP writes a request on day 0. That's performed on day 6 and reported on day 11, which shows a right mid-zone opacity. That goes back to the GP, who fills out a chest CT referral form on day 16. It's received on day 18 and performed on day 25 with a report on day 27 showing a right mid-zone cancer. The chest physician appointment is the following day on to day 28. And after a PET scan and biopsy, the patient's been on the pathway for 35 days, which falls below the standards set out in that SCP. And I think you'll agree there's too many steps in the process. So we needed to innovate and think differently, and we wanted to try and innovate the GP referred chest X-ray patients and do things differently. So we needed just to make things faster, to remove those inefficiencies, those bottlenecks, remove those unnecessary communications and be proactive in organising onward imaging tests ourselves. We were going to look at skills mix within radiology, so we fully utilised the staff base within the department. We were going to look at chest X-ray hot reporting and formulate a same-day radiographer-led chest X-ray hot reporting service supported by our consultant radiologist mentors. And we were going to initiate same-day access to CT scanning. Stakeholder collaboration was going to be key throughout this process to make this project successful. We'd had the innovative idea. We'd achieved some Welsh Cancer Network funding that allowed us to employ 3 trainee reporting radiographers, and 4 of us then undertook a course, postgraduate certificate in Birmingham City University. There's a plethora of evidence out there regarding the benefits of radiographer reporting, and that says that radiographers working within a defined scope of practice, having undertaken higher education, supported by consultant radiologist mentors, can provide reporting to a comparable standard to that consultant radiologist within a very small part of their role. MDT collaboration was essential and allowed us to formulate extensive patient information leaflets, GP information letters, and we formulated scripts with our chest physicians about the sorts of information that radiographers would be able to communicate to a patient regarding their chest X-ray findings, and we set up a red alert process to copy those urgent findings to the GPs and the chest physicians and the cancer services coordinator. The pathway looked quite complicated, but if we just concentrate on the abnormal stream, patient attends for a chest X-ray, they have an immediate chest X-ray hot report. If cancer is suspected, we discuss that with a radiologist, we offer same-day access to CT. We would normally report that within 24 hours, and we red flag those findings to the referring clinician, to cancer services and to the chest physician. So we started a pilot study in February 2020, which was radiologist-led reporting because we were still training. Unfortunately, COVID-19 reared its ugly head, and that paused our project till November of that same year, where we resumed that 2-session per week pilot study. The 4 radiographers qualified, and we gradually expanded that service to a 10-session per week service. The results were really encouraging. We managed to reduce our mean chest X-ray reporting time by 98%. We reduced our chest X-ray to CT scan time by 94%. Our CT scan reporting time went down by 30%. And most importantly, the chest X-ray referral from the GP to the first chest physician contact went down by 81%, from 45.7 days to 8.7 days, which we thought was a very good effort. So a post-project example timeline, which shows much more swift action from radiology. So everything was performed on day 1. The chest X-ray reported, the CT scan performed and reported, showing a T2 lung cancer. The chest physician appointment was on day 7, and the patient was in the MDT on day 9. So we hope to conclude, we've shown some significant time savings and innovation within this cohort of patients. MDT collaboration and communication has been key throughout this process. We've had a 98% reduction in chest X-ray reporting time, a 94% reduction in chest X-ray to CT scan time, and importantly, 81% reduction in time from the chest X-ray referral to the chest physician contact with that diagnostic CT result. We'd like the future developments to include geographical dissemination of these findings throughout Wales, as we think there's some important learning there for other health boards. We'd like to import some key themes from this transformational project into other single cancer pathways. Without all of the multitude of staff involved within this project, it wouldn't have been possible. So thank you very much to everybody involved.